All right, good evening. Welcome to Chapter 12 in Limited X-ray Operators Introduction to Anatomy, Positioning, and some Pathology. In this particular chapter, we're going to talk really specifically about how we position our patient, a little bit about the general anatomy, and also pathology of diseases. So let's get started. All right, so our objectives, we're going to talk about the difference between cells, tissues, organs, and body systems. We're going to list those systems of the human body. We'll talk about basic components and functions. Also describe the structure of bones. List 3 classifications of joints and give examples of each. We're also going to use correct terminology to talk about joint and joint motions. We're going to talk about anatomic position and demonstrate it. Also list and define the planes of the body. Use correct terminology to describe anatomic locations, relationships, and also correct terminology when referring to radiographic positioning and projections. And then also, given a position projection description from one of the following chapters, select and mark and place the image receptor correctly. We'll talk about how we put the image receptor correctly, the marker on place. And then modify standard procedures to produce quality images, especially those in obese patients. And then define some common terms to describe or classify disease processes. We also need to be able to explain the difference between acute and chronic, and then define inflammation and describe its possible consequences. All right, so the organization of the human body. Well, as we have talked about this over and over again, the body's made up of a lot of different stuff. First off, chemicals. The body's made up of chemicals, and the chemicals, have atoms and also molecules that are contained within them. Cells, they're the smallest unit of living things. And then tissues are cells working together to perform a specific function. And then organs are groups of tissues that perform specialized functions. And then systems equals groups of organs that perform complex particular functions that make the body work. And then the body is composed of all the systems. So let's talk about specific body systems. Integumentary. Hey guys, that's the skin. If you remember back in your training days of 101 anatomy physiology, it secretes oil and sweat in response to pain, pressure, touch, and temperature. It is the largest organ of the body, and it does a really immaculate job in preserving us and maintaining homeostasis. Then you have the muscular system, which helps control movement and body temperature. The nervous system, which is multiple components itself, peripheral nervous system, central nervous system. It conducts impulses between the central nervous system and other body parts. And then your endocrine system, obviously it secretes hormones to regulate body functions. The endocrine system is a huge part of your body that probably just about 90% of every cell and every organ and tissue has some kind of relationship with the endocrine system. All right, so circulatory system, that obviously being our heart, our pump, and then all of the corresponding veins and arteries that go with it, that's transporting the blood throughout the body. Your lymphatic system provides lymph for the movement of fluid and certain molecules, and also, big important thing, it assists with immunity. And then finally, your respiratory. This is the portion or the system of our body that is responsible for exchanging gases, specifically carbon dioxide and oxygen. Digestive, the functions in digestion of food. We have to digest our food so we can use it for fuel to create energy. And then urinary system, obviously, is how we eliminate our excess fluid and also waste. Reproductive system is how we support reproduction, how we reproduce, new humans. And then the skeletal system, which provides the framework for the body. Those are your body systems. So in radiography, we deal primarily, but we do have to keep in mind all the other systems as well, with the skeletal system. It is divided into 2 portions, the axial and the appendicular portions. Your axial is being your center body mass, okay, your trunk. Your appendicular portions would be everything else. It's your appendages. Your total skeletal system is 206 bones. Primarily, it's 206 bones that are connected with cartilage and ligaments and tendons. Ligaments connect bone and cartilage, and tendons attach muscles to bone. All right, so bone structure. The cortex, okay, the cortex is the hard outer portion, okay, the cortex is the hard outer portion of the bone. Then the cancellous is the spongy, okay, the weird spongy materials that are inside, it's the spongy inner portion. The medullary canal, okay, is here. All right, so it's the canal that is in the central cavity, that is the central cavity. The periosteum is the fibrous outer membrane. Okay, there's your periosteum there. And then long bone structures include the diaphysis, which is the shaft diaphysis. Okay, the metaphysis, which is the end of the diaphysis. Okay, the metaphysis, and the epiphysis, which is the rounded joint that form the end. So here's your epiphysis here, and your epiphysis here. Very good. All right, so types of bone, we have long bones, we have flat bones, short bones, and irregular. Your long bones are thick cortex and also have a medullary canal. Examples would be the humerus. Short bones are thin cortex and lots of cancellous bone. Examples would be your wrist bones. Your irregular is various shapes, such as an example of that would be your vertebrae. And then your flat is thin cancellous layer between two layers of cortex, such as the scapula. All right, so joint types, synarthrosis, which is removable or immovable, sorry, not removable. Synarthrotic, which is immovable, otherwise it's fixed. An example of that would be the skull. Amphitheatus, okay, which is an example would be the vertebrae because of the different shapes. And the diatherosis, okay, an example of that would be the hip. All right, so in joint movement, you have circular motion, which is an arch-like rotation of structure around the axis. Then you have rotation, which is a pivoting of bone on its axis, such as like in the reference to C1 around C2. Circumduction moves the distal end of the bone in a circle. This results in a conical shaped motion. A good example of that is the arm at the shoulder. Then you have supination, which is a lateral, okay, or external rotation. Lateral is towards the outside. Rotation of the bone, so the forearm, so the palm of the hand is facing up or anterior. Pronation is the opposite of subination. Okay, it is a medial movement or internal. Medial, internal versus lateral, external. So it's a medial or internal rotation of the bones of the forearm so that the palm of the hand is facing down or in a posterior fashion. All right, so angular motion is bending, resulting in a change in the angle between the long axis of the two bones making up the joint. Flexion is the bending motion that decreases the angle of two bones. So the elbow joint, so the forearm moves closer to the humerus, okay? So this is flexion, all right? Extension, all right, is the opposite of flexion. It's returning to the anatomic position, okay, back straight out. So it's the elbow movement or elbow joint movement from flexion, returning to the anatomic position. Abduction versus adduction. Abduction is a movement of a part away from the middle or midline of the body, so arms straight out from the side. Adduction is the opposite of abduction. It's a movement towards the midline, so you're adding the appendage back to the body, not away from the body. Gliding motion occurs when one bone slides over another. These simple motions occur without any circular or angular movements. An example would be the movement of the patella over the femur with knee flexion or extension. Special movements are another type of joint movement which occurred in a limited number of joints to include inversion, which is turning of the sole or plantar surface of the foot inward. And then eversion, which is the opposite of inversion, is turning the sole of the foot outward. You have protraction, which is moving the part forward or anterior, such as holding your arm straight out in front of you. That requires protraction. And then retraction is the opposite of protraction. It's moving a part backward or posterior towards the back of the body. And then, of course, elevation, I think is pretty simple. We know that. It moves the part up or superior. And depression would be moving it down or inferior. It'd be the opposite of elevation. Positioning terms. This is the anatomical position. Notice that the palms are facing towards us. So patient facing forward, arms extended, palms forward. Radiographic position is very important on this. This is the placement of the body part for the procedure. So this radiographic position, we must know what it is for whatever the image is that we're trying to develop. And then, of course, radiographic projection is the path of the central ray. He looks very happy. Happy boy. Right, so the body planes, they're used to place the patient in proper position. The median or mid-sagittal plane is here, okay? It involves the medial or the center part of the body, okay? The coronal or the frontal plane is that flat surface, okay? That's what we're talking about here. It is the anterior or posterior projection, okay? Either front or back. It is separated by the coronal or the frontal plane. Then finally, the transverse or horizontal plane, as you can see, there's a cross section this direction here. Very good. So we're describing how the patient's body is oriented. Either they're prone, okay, prone is when they're face down. Recumbent, they're on one of the side, either your dorsal recumbent or lateral recumbent or ventral recumbent. Supine, the patient is on their back, supine. And then upright, obviously the patient is sitting upright or standing upright, either one. All right, so in these radiographic position, we're talking about how the relationship of the X-ray table of the IR. Dorsal decubitus is C, okay? This guy right here, he's dorsal decubitus, all right? He is on his back versus down here in D, let me minimize myself. D, okay? He is ventral decubitus, ventral decubitus. And then lateral A and B here. Here you go. This is a left lateral. This is a right lateral because we always consider the patient. And then over here is your left lateral recumbent. And then, of course, representations, lordotic is the patient that's sitting upright. And then with oblique, you have different angles. Otherwise, the patient is at some angle. Let's see if I can do this correctly. Yeah, they're at some angle, one way or the other. That's oblique. All right, so the path of the central ray from the X-ray tube, okay, through the patient to the IR is where our projections are important. That's where we get them from. Names that may correspond to the entrance and exit portions of the CR include AP, which is anterior posterior, so we're going from front to back, or PA, which is posterior to anterior, that's from back to front. Lateral, which is a side, oblique, which is a angular position, axial, and also tangential. So let's look at those guys. There you go. There's your AP projections. You have anterior to posterior, and from posterior, or PA, from the back to the front. Okay, so there's your AP and PA projections. AP and PA. Bingo. All right, so lateral projections, left lateral, right lateral. Remember, we're always talking about the patient's right and the patient's left, anatomic. And here's your oblique positions, okay? This is an oblique position here, A. Oblique position here, C. Okay, here's an oblique position, B, and also D. Very good, good stuff. All right, and these are your axial positions. Notice that they are angular. Okay, this is what we mean. We're doing angular projections to try to get a particular image, maybe a focus of the pelvis or a focal of the spine, whatever the physician or practitioner needs. they're doing axle, types of imaging. Notice this is your tube, this is your collimator, this is your CR, and there's your IR. Okay, and this distance, as we remember, is your SID. Very good. All right, and there's your tangential projections. These are much difficult. This is going to be your IR. This is going to be your tube and your collimator. There's your collimator there, your tube, and this is going to be your IR. Now, these are very difficult types of x-rays to obtain, but they're looking for something very, very specific up in the area of the knees, the distal ends of the femurs and the distal ends of the tibias. So tibia fibulas. All right, here we go. Components of radiographic procedure: patient assessment, interpretation of the procedure request, effective communication, selections and orientation of the IR, proper alignment of the CR and the body part and the IR. All right, folks, we need to assess our patients. We need to talk to our patients. We need to get their permission. We need to understand, what the image is that's being requested by the practitioner, and we have to have good, effective communications. If we look at this particular representation, this is not the way to do it. Okay, look, this person is very hyperextended to try to get their chin up on the top of the Bucky system. This is a wall-mounted upright system, image receiver. This is a Bucky, and your cassettes in here. This is your cassette tray. And also look at the columnization. The columnization is pretty narrow. You're not going to get all of the chest field. So this should be down. Okay, we should move our upright down a bit. Positioning is good. Collimation is bad. We just need the height adjusted so that the patient's a little bit more comfortable. Bring that down so he's not quite as flexed like that. So could have been a little bit better positioning on this particular one. All right, so here we go. We got collimation. We can see here this person is doing a hand. This is a left hand. Notice that this is the marker that's placed on the IR. This is your IR here, your image receiver. Right, so the hand is directly on the IR there, up on top of the table. Patient's appropriately placed. Columnization is not bad. Here's your good focal point. All right, and looks like we're good. So we've got appropriate radiological marker placement, the patient pre and post period of procedure instruction. We're going to make sure we select the right factors. And then, of course, we'll evaluate the clarity of the image. We've got good density, we've got good contrast, and then process it for the practitioner to look for. All right, so imaging of the obese patient. These are large body parts. With this weight approaching or exceeding equipment limits, we need to be very careful over. Presence of significant skin and fat folds can be very, very difficult to x-ray. And then any decrease in mobility may require changes in our usual procedures. So imaging of the trunk poses the greatest challenge because the most common position landmarks may not be located. You may have to really dig in there to find what you're looking for. In addition, your columnization is very, very hard in larger patients as well to get good columnization because of the excess of tissue. All right, so let's talk about it a little bit. Procedure to image the abdomen in the obese patient. First off, we need to locate the jugular notch here. Okay, there's your jugular notch, which is easily located at the superior aspect of the sternum, and tape a visible marker at that location. We want to put a little marker there. Then use your tape measure. It can be used to locate the level of pubic symphysis. So now we're going to go from the notch all the way down to the pubic symphysis, and which will specifically define the inferior aspect of the abdomen. So it's going to tell you that distance, and it's normally, if people are greater than 5 feet in height, in the average person, it should be 21 inches. And then, of course, 5 to 6, 22, 6 foot, 23. But if you have the patient, I'm going to try to draw this, I'm not going to guarantee, and the patient, whoo, there's his belly, okay, and there's his legs, so his symphysis pubis is here, and his notch is here, and you're measuring that tape, you've got all this distance to cover. So it's going to be greater than these distances, and that's what you're going to have to start deciding on your compensation factors to adjust KVP and MA. So yeah, this is your patient. Ooh, biggin. Okay. Woohoo. All right. Like I said, I didn't promise that I could draw very well. All right, here we go. All right, so remember that the field light indicating collimation radiation field will appear small on obese patients. The field light scales on the X-ray tube collimator must be set to the IR size or desired radiation field rather than relying on those visual clues. Pathology. Okay, it's the study of disease processes that includes identification of the disease and also classification. So identification is diagnosis or identification by evaluation of signs and symptoms. And then the prognosis is developed based on the patient's potential outcome or probable outcome of that disease. Classifications of patients: acute, which is sudden onset; chronic, which obviously is something that is going on for a long period of time; structural versus functional. Is it a structural issue that is something that just, provides structure to the body, shape, form, that kind of stuff, versus is it something that's functional that allows for the body part to move? And then, of course, hereditary and congenital. I think those are pretty self-explanatory. Endogenous versus exogenous is something that is within and within cause, and this is something from without cause, from the outside of the body cause, from the inside of the body cause. Trauma, hey, that's probably one of the #1 reasons why we're taking an X-ray. This is a physical injury resulting from an object, and it can be either blunt or penetrating. Types of injuries that we normally see as limited operators are all of these. We're taking a look and we find dislocations, sprains, strains, lacerations, abrasions, contusions, and then ultimately we're trying to get pictures of the fractures. All right, so these are some of the different fractures. This is an injury in which the bone tissue is broken, okay? The term compound means when the broken bone penetrates the actual skin, and we can see it through the surface. The term simple is when the skin is not penetrated. So here's your different fractures, okay? This is your green stick fracture, which is usually in children. This is a spiral fracture. This is definitely a separation fracture, a very complicated type of fracture. This is a commutated fracture. This is a transverse fracture. This is a compression fracture, depressed skull fracture. And then this would be very related to probably right down at the end, some kind of avulsion type of fracture. Yeah. This fracture here is an overriding fracture. Yeah. This would be like an avulsive type of fracture where it's right off the tip. Okay. All right, so inflammation. Hey, inflammation is important to understand. It's your body's response, and usually this is an immune system response. It's a response to some kind of cellular insult. Something has attacked the cells, so now there's a bunch of inflammation. Some of it can be very, very serious, such as an anaphylaxis from a bee sting, spider sting, ants, whatever the case may be, some kind of envenomation process, or even something as simple as a food allergy. Or in radiographic, sometimes we give dyes and people don't know they're allergic to it, and they have an inflammation response. The characteristics of inflammation responses include swelling and edema, throat, the tissues themselves, reddening of the tissue, heat at the infection site if it's an infection related, and potentially sepsis, and also pain. And then degeneration or further cell and tissue injury when it's chronic, when it's a long-term, especially if it's something that's a long-term sepsis or some kind of fasciitis, that kind of thing. So it's, degeneration of those cells. Right, so neoplasms, they're either growth of tumors. Benign tumors remain at one body location and have very limited growth, versus malignant tumors or malignant cancers. They invade surrounding tissues and are capable of metastasis, which just means it's moving from one location to another. All right, so in summary, we talked about levels of organization in the body to include chemical, specifically atoms and molecules, Cells, tissues, organs, and the systems, the body systems themselves. These are all of the body systems that we discussed. I'm not going to individually read these out. Remember, we did these. The skeleton contains 206 bones. Make sure you know it, that number of 206 bones. And then it's divided into axial and appendicular. Bones are classified as either long, short, flat, or irregular. Bone structure includes cortical and cancellous tissue, medullary canal, and also the periosteum. Joint classifications are synthrotic, epithrotic, or dithyrotic. Syntherosis, amphitherosis, or diatherosis. So those are the different classifications of joints. Typical joint movement includes circumduction, rotation, angulation, and gliding. And then anatomic position serves as a point of reference for us when describing radiographic positions and projections. Sagittal, coronal, and transverse planes are used to properly position the patient. Placement of the patient's body may be described as recumbent, supine, prone, or erect. Patient body part placement in relationship to the X-ray table and or the IR may be referred to as the cubitus, lateral, lordotic, or oblique. And then the terms to describe radiographic projections include anterior posterior, which is AP, posterior anterior, which is PA, lateral, oblique, axial, and tangential. Components of the radiographic procedure include patient assessment. Remember, you need to get to know our patient, introduce them, make sure that we have their permission to do the X-ray itself. The interpretation of the procedure request that the practitioner is asking you to do. Communication, selection, and orientation of the IR. Alignment of the CR and the body part and the IR itself. Image labeling to make sure we label it correctly. We give good patient instructions. We select the correct exposure factors and evaluate the radiographic image and adjust it accordingly. Obese patients, hey, all I can say is they may be very, very difficult. They have a very large part diameter, weight approaching exceeding limits, present very significant skin folds and those kind of things, and they can be very challenging. Make sure that you have help. Don't do these kind of patients by yourself. That's part of the safety. And also, make sure you're involving your practitioner for any adjustments that need to be made in KVP or MAs or, plain and simple, in the X-ray exposure time, anything that you're going to have to do that could potentially expose this patient to more radiation than normal. All right, so again, radiography of the abdomen is most challenging in those obese patients because of the symphysis pubis, including the inferior aspect of the abdominal cavity, cannot be located easily. So it's difficult to really find everything and get a good measurement of how much additional girth that the patient has. Pathology involves identifying and classifying diseases. Skeletal trauma may result in compound or simple fractures. Inflammation is an immune system response. Cellular injury is characterized by swelling, reddening, heat, and pain. And neoplasms are tumors that may be either benign or malignant. All right, folks, thank you again for attending this lecture. You can send us any questions you may have. If you're an EMET student, student at emets.net. If you're a METCI Institute student, student at metciinstitute.com. Thanks again. Have a great day, and we'll see you next time. Thanks.